Ocular Pathology Review, Part 3, The Retina and Vitreous Humor.
From the Department of Pathology at the Wills Eye Hospital and the Sidney Kimmel Medical College at Thomas Jefferson University.
The retina is the inner sentient layer of the eye. It is composed almost entirely of cells which are arranged in a lamellar fashion.
Ophthalmologists need to know the layers of the retina in this era of OCT. These are discussed at greater length in the introduction to anatomy and histology video. Hemorrhages and exudates. The retinopathies that occur in different diseases are composed of combinations and permutations of 5 types of hemorrhage and 2 types of exudates. The shape of retinal hemorrhages is governed by the location of blood within the retina. Flames or splinter hemorrhages are located in the superficial layers of the retina within the nerve fiber layer. In this area, the erythrocytes track along the axons of the retinal ganglion cells. Deeper in the retina, the axons of the bipolar of the photoreceptors and other deeper neurons are arranged perpendicular to the plane of Bruch's membrane. You can think of the axons as acting as a fence or corral that confines the blood into a round configuration, forming the blot and dot hemorrhages. Hemorrhages are seen in this diagram, the flame hemorrhages in the nerve fiber layer, the blot and dot hemorrhages in the deeper retinal layers. This patient has a sub-RPE hemorrhage. These tend to be darker and may be confused with tumors. There's also a hemorrhagic detachment of the internal limiting membrane, which is breaking through into the vitreous, forming a vitreous hemorrhage. Hemorrhagic detachment of the internal limiting membrane is one of the 2 types of bode or scaphoid hemorrhages that have a fluid level. The other type is the subhyaloid hemorrhage, characteristically seen in diabetics, where blood is located between the IOM and the posterior hyaloid of the vitreous, which has undergone detachment. Hemorrhagic detachment of the internal limiting membrane, in my experience, occurs most often in eyes obtained post-mortem from infants with abusive head trauma or shaken baby syndrome. Here we see some of the manifestations of that. Retinal hemorrhages too numerous to account that extend out to the ora serrata, that include these round so-called cherry hemorrhages, which are the hemorrhagic IOM detachments. There's also characteristic retinal folds, typically surround the fovea, and these are caused by vitreoretinal traction, seen in figure E. Higher magnification showing multiple cherry hemorrhages, and here's histopathology of a very large hemorrhagic detachment of the IOM in abusive head trauma. Again, here's an example of the retinal folds and the numerous retinal hemorrhages. Other characteristic features, of course, include optic nerve sheath hemorrhage. Shown in this case, the blood is largely located in the subdural and arachnoid spaces. This is a rather spectacular example. Blood tends to be, the largest amounts of blood tends to be located in the ampulla closest to the back of the globe. This case also has retinal hemorrhages and retinal folds. Blood-retinal barrier. The blood-retinal barrier is sort of analogous to the blood-brain barrier. It's a series of anatomic specializations that prevent the retina from being overwhelmed with excess fluid and metabolites. It has 2 portions. The inner portion is composed of tight junctions joining the vascular endothelial cells. This is a human retina that had an injection of fluorescein dye prior to enucleation. You can see that the fluorescein is confined to the retinal vessels. The outer portion of the blood-retinal barrier is actually the retinal pigment epithelium. The RPE cells are joined together by apical tight junctions. The capillaries of the choriae capillaris are leaky and fenestrated, so we can see the entire choroid is filling up with green dye. If you have problems with either the inner or outer portions of the blood-retinal barrier, this can lead to the accumulation of fluid, lipid, and protein, generally in the watershed between the two circulations. This is typically the outer plexiform layer of the retina. Hard exudates classically are said to be pools of proteinaceous fluid in the outer plexiform layer, shown here. In the outer plexiform layer surrounding the fovea, the Henle fiber, or the axons of the photoreceptors, are arranged in a radial fashion. This is responsible for the macular star figure, the hard exudates in the radial perifoveal Henle fibers, as shown in the cartoon and in a real case above. Another type of exudate is composed of macrophages that have ingested lipid that are present in the subretinal space and outer retinal layers. I've seen this several times, and I've been quite impressed by this. Nice example in the gross photo on the left. Cotton wool spots used to be called soft exudates. They're not really exudates. They're areas of focal blockage of axoplasmic flow within the ganglion cell axons. They are superficial. They're present in the territory of the radial peripapillary capillaries. And they typically block vessels. The ones in this photo didn't read the book. Here's histopathology showing thickening of the nerve fiber layer in the case of cotton wool spots. Structures here are cytoid bodies under higher magnification. They look like cells, but they're actually focal areas of axonal dilatation. Blocked subcellular organelles give rise to this pseudo-nucleus in the cytoid body. Blockage of a precapillary arteriole leads to focal retinal ischemia. As the axoplasm flows from the ganglion cell, when it enters the areas of ischemia, it gets blocked and the axon blows up like a balloon, forming the cytoid body. Again, cytoid bodies, or cotton wool spots, are a clinical marker for retinal ischemia, and they represent focal blockage of axoplasmic flow in the ganglion cell axons. Here's a nice pair of photographs of a patient with diabetic retinopathy and multiple cotton wool spots. We can see that the cotton wool spots correspond to areas of capillary non-perfusion disclosed by the fluorescein angiogram. So they're a marker for retinal ischemia. This is a old case from Dr. Reimer Walter's practice. It's a silver stain showing the dilatation of the axons in a cotton wool spot. Angioid streaks. Angioid streaks are not vessels. They have sort of a vascular appearance. What they actually are breaks in Bruch's membrane, which is calcified. There's certain conditions associated with angioid streaks. The most important is pseudoxanthoma elasticum. They're also seen in Paget's disease of bone, some cases of Ehlers-Danlos, and rarely in sickle hemoglobinopathy. Angioid streaks do predispose to subretinal neovascular membranes, particularly when they're present in the region of the fovea. Here's a patient with angioid streaks, a typical neck skin manifestations. Here we see a histopathology from a patient with hemoglobin SS disease. We can see the massive thickening of Bruch's membrane and the break. Conditions that predispose to angioid streak formation include pseudoxanthoma elasticum, Paget's disease of bone, Ehlers-Danlos syndrome, and rarely in sickle hemoglobinopathy. In some instances, they appear to be idiopathic. It's a question whether a lot of these patients may have mutations in the pseudoxanthoma elasticum gene. Angioid streaks do predispose to subretinal neovascular membranes, particularly when they are present in the macular region. And here's a patient with pseudoxanthoma elasticum showing the classic the skin lesions in the neck. They also occur in the axilla. Histopathology of a streak is shown below. This is a patient that had actually hemoglobin SS disease. Brooks membrane is thickened and blue, it's calcified, and it's ruptured. The retina is normally transparent. Light has to pass through the entire thickness of the retina to interact with the rods and cones. Central retinal artery occlusion causes infarction of the retina. The infarcted retinal cells become opacified, and this leads to a milky opacification of the infarcted retina. This patient has a cherry red spot. Why do you get a cherry red spot? Well, the retinal cells in the floor of the fovea are not supplied by the central retinal artery, so they remain alive and transparent. We have a window to the choroid in this area. Here's another example of a central retinal artery occlusion, which is diffuse milky opacification. Now, this patient has a cilioretinal artery, so there's this little juxtapapillary focus of retina that is viable. So this patient would have a small area of vision. Another example of a cherry red spot. Central retinal artery occlusion. You can have atherosclerosis of the central retinal artery at or posterior to the lamina cribrosa. Many cases are due to emboli. You have cholesterol emboli, Hollenhorst plaques, platelet fibrin emboli, calcific emboli, typically associated with rheumatic heart disease. And there are cases of artery occlusion caused by tumor emboli, classically atrial myxomas in young patients. Vasculitis can also give rise to artery occlusion and ischemic optic neuropathy. You always have to worry about giant cell arteritis and do the appropriate laboratory tests. Here's an example, a patient that returned a week after orbital surgery with NLP vision and a milky retina. We compare the fellow eye with the eye with the artery occlusion. You can see the area of the central retinal artery, the territory is totally involved in the artery occlusion. After an artery occlusion, all of the layers supplied by the central retinal artery undergo atrophy. This leads to the appearance of interischemic retinal atrophy. You don't see gliosis either because the glial cells reside in the same area and are also killed by the little mini stroke. Here's a nice example of a branch artery occlusion, the normal retina shown on right with the thick layer of perifoveal ganglion cells and the interischemic retinal atrophy in the territory of the branch artery occlusion. You get interretinal atrophy in glaucoma, but it just involves the nerve fiber and ganglion cell layer compared to the multiple layers involved in interischemic atrophy. Arteritic interischemic optic neuropathy is caused by giant cell arteritis. Here we see the histopathology, the markedly narrowed lumen of the vessel, and the inflammation in the vessel wall, typically centered around the plane of the internal elastic lamina, which is frequently lost and shows segmental disruption. Now, this is a case of florid granulomatous inflammation with multiple giant cells. Now, you don't see giant cells in all cases. I get very concerned when I see any chronic inflammation within the vessel wall. So giant cells are not necessary for the diagnosis. Okay, here are Tay-Sachs, the other classic cherry red spot in Tay-Sachs disease. We're dealing with a window in the opacified retina, but the mechanism of opacification is different. The perifoveal retina, where the ganglion cell layer is thickest, is opacified by the accumulation of GM2 gangliosides in the retinal ganglion cells, shown in the PAS stain below. Again, this is due to deficiency of hexosaminidase A. Retinal vein occlusions comprise of the so-called blood and thunder fundus of the squash tomato sign. Retinal vein occlusions typically, most commonly, are branched and involve the supratemporal artery, or to supratemporal vein. The associations are listed here: hypertension, arteriosclerosis, diabetes, local causes. Most cases of vein occlusion are related to concurrent arterial disease. A sclerotic artery impinges on the vein in a common adventitial sheath, leading to disrupted flow and occlusion. When I started in ophthalmic pathology, one of the most common types of eyes we received in the lab was an eye with neovascular glaucoma following a vein occlusion. This was called 90-day glaucoma. There was actually a 20% incidence in ischemic vein occlusions. We don't see this type of glaucoma, that type of eye, that often due to improvements in therapy. Vein occlusion gives rise to hemorrhagic infarction of the retina. We see wall-to-wall retinal hemorrhages, cystoid edema, hemosiderin, neovascularization, and what have you. The type of patient that develops the neovascular glaucoma and tends to have more severe visual loss are patients with the ischemic vein occlusions. And one of those is seen on the right, top right. We can tell it's ischemia because we see all those cotton wool spots, which are the clinical marker for ischemia. Retinal arteriosclerosis is a response to chronic hypertension. This leads to the accumulation of layers of fibrosis in the wall of the vessels. Now, retinal vessels are also, when they're healthy, they're transparent. When you look in with the ophthalmoscope in a healthy person, you're seeing the blood in the vessels. You're not seeing the vessels. If you develop arteriosclerosis, the fibrosis in the vessel wall opacifies the blood column, and this leads to the appearance of copper wiring. It also blocks the underlying veins, and this is one of the causes of AV crossing defects or AV nicking. Here's histopathology showing fibrosis in the vessel wall. Another example with the Masson trichrome stain showing fibrosis. Here's our copper-colored vessels, or copper wiring, and AV crossing defects. In malignant hypertension, if the pressure is high enough and is present long enough, this can lead to focal spasm of the arteries. If the spasm is severe enough, it can give rise to vascular necrosis and vascular incompetence. And this is responsible for the spectrum of changes that we see in malignant hypertension, or you have poorly formed macular star figure. In this case, there's retinal edema and multiple cotton wool spots. Now, one thing we don't have in this photo is optic disc edema. Optic disc edema can occur in some patients with severe hypertension, and you should always remember to take the blood pressure when you have a patient with disc edema.
A variety of drugs and toxins can damage the retina. These include gentamicin, hydroxychloroquine or plaquenil, pentosan, meluril, methoxyflurane, quinine, tamoxifen, and nicotinic acid. The intraocular injection of gentamicin can cause retinal necrosis. Chronic use of the psychiatric drug meluril caused blindness in the patients shown in this fundus photograph. Retinal oxalosis was associated with the use of an anesthetic called methoxyflurane. The breast cancer drug tamoxifen causes crystalline retinopathy in some patients. Visual loss can be caused by megadoses of the vitamin nicotinic acid or niacin. It is a cause of non-leaking cystoid macular edema. Chronic use of hydroxychloroquine or plaquenil causes a bullseye maculopathy and a flying saucer sign on OCT, which discloses parafoveal photoreceptor atrophy. Penisan or Elmiron is a drug that is commonly used to treat interstitial cystitis. Recently, it has been shown to cause a maculopathy. A number of lawyers are now specializing as Elmiron lawsuit attorneys.
Okay, the area centralis is the part of the retina defined as having a ganglion cell layer greater than a interrupted monolayer. It's actually a better term than macula. Macula lutea means yellow spot. Within the center of the area centralis is the pit or fovea, 1.5 millimeters in diameter, about the same diameter as the optic nerve head. And of course, the foveola is present in the floor of the fovea. This is the only part of the retina that actually sees 20/20.
Ocular coherence tomography has revolutionized retinal diagnosis during the past decade. The OCT of a patient's fovea and the corresponding histopathology are seen in these photos. It is evident that the layers disclosed by OCT do not correspond directly with the histopathology. For example, the dark band in the outer retina contains more than the outer nuclear layer. It contains both the outer nuclear layer and the inner plexiform and outer Henle fiber parts of the outer plexiform layer. A proposed lexicon for anatomic landmarks in OCT was published in the journal Ophthalmology in 2014. The landmarks are shown in this figure from that paper. This paper by Spade and Curcio in the journal Retina discusses the anatomic correlates to the bands seen in the outer retina. These four relucent bands help the ophthalmologist to assess the health of the outer retina. They include the external limiting membrane, the ellipsoid zone of the photoreceptor inner segments, that previously was called the ISOS junction, the cone outer segment contact cylinder region, that previously was called the outer segment tips, and the RPE. The ellipsoid layer is a good clinical marker for healthy photoreceptors. The outer retinal layers are seen in this photomicrograph. The nuclei of the photoreceptors comprise the outer nuclear layer. The inner and outer segments of the photoreceptors project through the external limiting membrane, and the tips of the outer segments interdigitate with the apical surface of the RPE. The inner segments and outer segments of the photoreceptors are seen under higher magnification in the inset. The myoid and ellipsoid parts of the inner segments are seen in these photos. The myoid abuts the external limiting membrane. The ellipsoid is tightly packed with mitochondria, seen in the electron micrograph at right. The mitochondria probably are responsible for the relucency of the ellipsoid in the OCT. In many OCT images, the vertical axis is magnified to facilitate interpretation. This OCT shows cystoid edema in the retina overlying a tumor. The L-shaped magnification bar at bottom left indicates that the vertical axis is magnified 3 times. In the bottom image, we use Photoshop to correct the vertical image to its actual size. A similar pair of photos shows the retina corrected to its actual thickness. Age-related maculopathy, previously called age-related macular degeneration or senile macular degeneration, is a major public health problem that affects approximately 9% of the United States population and is expected to increase as the population ages. The disease is also quite costly. Between 2013 and 2016, Medicare spent $11.3 billion on Eylea and Lucentis, 2 of the anti-VEGF drugs used to treat the exudative form of the disease. These 2 drugs accounted for more than 12% of Medicare's total budget for drugs. Age-related maculopathy is the clinical spectrum that includes both dry or atrophic variants and wet or exudative variants.
Both variants can occur in a single patient.
And the CATT study showed that the atrophic form can develop in patients with exudative maculopathy after anti-VEGF therapy.
Patients with atrophic AMD typically have a window defect in the retinal pigment epithelium.
Photoreceptors are lost in the area of RPE atrophy. This is evident as loss of the ellipsoid zone in the corresponding area. The photoreceptors die because they need healthy RPE to survive. Increased transmission of light into the choroid also reflects loss of the RPE. This photo shows an extremely large area of RPE atrophy in a 92-year-old man with advanced dry AMD. The margin of the window defect is seen under higher magnification in this photo. The choroidal vessels are readily evident as white lines in the window defect. This appearance used to be termed choroidal sclerosis, but it should be obvious that the vessels do not become abruptly sclerotic when they enter this area. They appear this way because they're visible. Here's a photomicrograph of that patient's fovea. Although a nice foveal pit is present, the outer retina is markedly atrophic. There is total absence of the outer nuclear layer in the photoreceptors. It is not surprising that this patient was legally blind. Here's a higher magnification photo stained with PAS. The ganglion cell and internuclear layers are well preserved, but the outer nuclear layer and photoreceptors are totally absent. The PAS stain highlights the internal limiting membrane and Bruch's membrane, which shows aging changes. Under higher magnification, we see that both the RPE and the choriocapillaris are absent. The characteristic triad found in atrophic AMD is evident. This includes RPE loss, photoreceptor atrophy, and involution of the choriocapillaris. The spaces where the choriocapillary vessels were located are delimited by PAS-positive intercapillary columns that extend from the bottom of Bruch's membrane, but the choriocapillary vessels are totally absent. Here's another case of so-called choroidal sclerosis with a large RPE window defect. We see the same characteristic triad of RPE loss, photoreceptor atrophy, and involution of the choriocapillaris. Some types of retinal pigment epithelial drusen are associated with age-related maculopathy. Drusen are focal deposits of extracellular debris that are located between the basal lamina of the RPE and the intercollagenous layer of Bruch's membrane. They have a complex composition, and a number of confusing classification schemes have been proposed. Drusen are thought to be made by sick or stressed RPE cells. Hard or cuticular drusen are globular excrescences of densely hyaline PAS-positive material on the inner surface of Bruch's membrane. They can be found throughout the fundus, and their association with age-related maculopathy has been questioned. In contrast, soft drusen and basal linear deposits are risk factors for AMD. This photomicrograph shows a soft drusen detaching the retinal pigment epithelium. Two forms of diffuse soft drusen, basal linear and basal laminar deposits, have an important association with choroidal neovascularization, disciform scarring, and visual loss. They adhere poorly to Bruch's membrane and predispose to RPE detachments and tears. They provide a plane for neovascular ingrowth and displace the RPE from its blood supply. They may be a physical barrier to diffusion of metabolites and wastes, and they may prevent interactions between the RPE cells and the endothelial cells of the choriocapillaris. A basal laminar deposit, shown here in this electron micrograph, is a thick diffuse layer of extracellular matrix material that's located between the plasma membrane and the basement membrane of the RPE. A basal linear deposit is a diffuse layer of multivesicular phospholipid material that's located between the RPE basement membrane and the intercollagenous zone of Bruch's membrane. The basal laminar deposit, shown in this cartoon, is composed of abnormal 1,000 angstrom banded basement membrane material. The multivesicular phospholipid, comprising the basal linear deposit, thickens the inner portion of Bruch's membrane. In one series, 84% of patients with wet AMD had basal laminar deposits, and they were found in approximately half of the patients with dry AMD. Basal laminar deposits may not be evident clinically. These sheets of soft drusenoid material may involve a significant part of the macula. In his 1992 Zimmerman lecture, Dr. Dick Green stressed that basal laminar deposits and basal linear deposits, but not nodular drusen, are important associations with choroidal neovascularization, disciform scarring, and visual loss. According to Dr. Christine Curcio, Aging changes in Bruch's membrane lead to the accumulation of multivesicular material in the space between the basement membrane of the RPE and the intercollagenous layer of Bruch's membrane. The material is composed of large apolipoprotein B and E and cholesterol-rich lipoproteins that accumulate as large soft drusen and extensive sheets called basal linear deposits. The material also can accumulate as smaller focal deposits in the subretinal space called subretinal drusenoid deposits. The multivesicular material is thought to represent unneeded lipids secreted by the retinal pigment epithelium that's derived from the diet and the continual phagocytosis and digestion of photoreceptor outer segments. The continual and gradual accumulation of the soft drusenoid material beneath the RPE leads to an atherosclerosis-like process that has an inflammatory component. This leads to the death of the RPE and the successive loss of photoreceptors in patients who have the dry or atrophic form of age-related maculopathy. It also promotes choroidal neovascularization with resultant retinal edema, serous and hemorrhagic retinal detachment, subretinal fibrosis, and disciform scar formation with severe visual loss in patients with the wet or exudative form of the disease. This diagram from one of Dr. Curcio's papers shows the accumulation of the soft drusenoid material forming soft drusen and basal linear deposits on the inner surface of Bruch's membrane. A small focal subretinal drusenoid deposit is also seen in the subretinal space and in these electron micrographs. I personally have never seen them in routine microscopic sections. Subretinal drusenoid deposits are evident as reticular pseudodrusen, shown in this fundus photo. Choroidal neovascular membranes are important components of exudative or wet AMD. The neovascular membranes are categorized by the location of the new vessels. Type 1 or occult neovascular membranes are located between Bruch's membrane and the RPE and are poorly demarcated on fluorescein angiography. An occult type 1 sub-RPE membrane is seen in this photomicrograph. Class 2 or classic membranes are located in the subretinal space anterior to the RPE and are well demarcated on angiography. Type 3 retinal angiomatous proliferations, or RAPs, initially are thought to form in the deep capillary plexus of the retina and then invade the subretinal space, where they may form retinal choroidal anastomoses. The subretinal neovascular membranes leak, leading to retinal edema, exudation, hemorrhage, focal serous detachment of the retina, and hemorrhagic detachment of the RPE. Subretinal hemorrhage can undergo organization and fibrosis. In the late stages, this can progress to disciform scar formation, essentially a solid collagenous detachment of the retina. Powerful drugs like ranibizumab and aflibercept that target VEGF restore and preserve vision in many patients with exudative macular degeneration, but don't cure the underlying basis of the disease and have to be administered continually by frequent intravitreal injection. Chronic inflammation is thought to play a role in the pathogenesis of age-related macular degeneration. Inflammatory mediators and components of the complement system are found in drusen and damaged RPE cells. Age-related macular degeneration is strongly associated with a common variant of the complement factor H gene. One polymorphism of the complement factor H gene has been shown to markedly increase the incidence of AMD in homozygous patients. A number of pharmaceutical agents targeting components of the complement system currently are being investigated as treatment for atrophic AMD. My former chief, Dr. Harold Shea, used to tell macular degeneration patients that they would never go blind. They would lose their central vision, but would always be able to ambulate. This, of course, was long before the availability of drugs targeting VEGF. Dr. Shea's statement, while encouraging, was not entirely true. Patients with choroidal neovascular membranes who were on anticoagulant therapy occasionally would develop massive hemorrhagic retinal detachments and secondary glaucoma due to anterior displacement of the lens iris diaphragm. The blind, painful eye from one of these patients is shown in this macrophoto.
Okay, Here we see retina. There's a large incidental glaucoma cup in this case, but we see a yellow spot in the retina. Yellow spot is the macula lutea. That's what macula lutea is. It means yellow spot. The yellow pigment is derived from the diet. It serves as a yellow filter to filter out the damaging blue wavelengths of light. Dietary components include zeaxanthine or corn yellow and some carotenoid pigments from these colorful veggies. Again, the AREDS 2 study has confirmed that various combinations of vitamins may decrease progression of macular degeneration. Disciform scars occur in other conditions besides age-related maculopathy. This is an example of presumed ocular histoplasmosis syndrome. I'm not sure whether it's presumed anymore. I think the people have found a few organisms in some cases. Clinically, we see this triad of disciform degeneration, peripapillary atrophy, and punched-out chorioretinal lesions. In contrast to your typical age-related disciform scar, there's frequently associated inflammation. We can see the lymphocytic infiltration in the choroid. Macular holes. I'm totally amazed with macular holes that they can be treated. We now know that vitreoretinal traction plays an important role in the pathogenesis of macular holes. Vitreoretinal traction of the cortical vitreous sort of inverts the, flips the fovea, and this leads to the degeneration of the retina, cystoid edema, and hole formation. Cystoid macular edema. Again, a lot of people are looking at cystoid macular edema and retina with OCT when they're trying to follow patients with age-related maculopathy and determine whether they need new injections of anti-VEGF medications. Here's an example where we have a direct correlation between OCT above and histopathology below. This was a fairly young African-American man that had a very large RPE tumor out in the retinal periphery. Now, peripheral tumors can cause cystoid macular edema. It's one of the rare presenting manifestations of a peripheral tumor. Now, the OCT is shown above, and my technician we got lucky. The technician had a section right through the center of the fovea corresponding with the OCT. We can see that the spaces are present in the outer plexiform layer and in the outer nuclear layer. Here's a case where I got lucky. When I opened the eye, it sliced right through the center of the fovea, and again we see the spaces in the outer plexiform layer and outer nuclear layer sort of filled with this fibrinous material. So, cystoid macular edema. Retinitis pigmentosa is a phenotype caused by mutations in at least 150 genes. This goes up all the time. This is a very large heterogeneous group of diseases that share progressive photoreceptor degeneration. It's bilateral. Patients typically are blind by middle age. In the early stages of the disease, the rods are affected more severely than the cones. Patients experience night blindness, peripheral visual field loss, tunnel vision, and eventually total blindness. The retinal vessels become attenuated because there's nothing left to feed. There is waxy pallor of the optic disc, and classically peripheral bone spicule pigmentation, which is responsible for the name of the disease. Other interesting features that occur include a posterior subcapsular cataract, macular edema, and optic disc drusen in some cases. Here's histology of a patient with autosomal dominant retinitis pigmentosa caused by the HIS23 mutation in rhodopsin. This was the first genetic cause for retinitis pigmentosa that was discovered by Ted Draja up in Boston. Again, we see the inner retinal layers. The ganglion cells look normal. There's a good internuclear layer, but there is an interrupted layer of poorly preserved cones in the outer nuclear layer and no photoreceptors. So a loss of photoreceptors classically is found in retinitis pigmentosa. The bone spicule pigmentation results when retinal pigment epithelium, the epithelial cells, get access to the retina. Presumably there's no photoreceptors to contact inhibit them. They get inside the retina and they grow along the vessels. There's a higher mag, this perivascular RPE hyperplasia. You typically find large macromelanosomes. This is an interesting paper published 25 years ago by Anne Malam's group. It's still interesting, though. Here's a photograph showing the RPE invading and circling the retinal vessel. An interesting thing they found is that the RPE cells tend to elaborate what looks like a new Brooks membrane when they're in the retina. You have a new elastic layer. And the other interesting thing is that the retinal capillary endothelial cells develop fenestrations like the choroidal capillaries. So, as we said before, RPE, retinitis pigmentosa, is a phenotype. More than 3,000 mutations in 57 genes cause non-syndromic RPE. There is also retinitis pigmentosa associated with systemic syndromes. Here are some of the different genes that are involved. Some of these encode proteins involved in rod phototransduction, like rhodopsin, or responsible for 15 to 20% of patients with dominant retinitis pigmentosa. And we have things like rod cyclic GMP phosphodiesterase and cyclic GMP gated cation channel, arrestin, 1-late cyclase, activating proteins. Some of the proteins involved have an uncertain function. This is important. Note that 39% of 39% of patients with retinitis pigmentosa don't have a family history. They're new sporadic cases. The consanguinity is important in many instances, pretty common, and it's generally said that the X-linked cases are worse than the recessive that are worse than the dominant. Of course, it depends on which mutation you have. Here's another hereditary condition, juvenile X-linked retinoschisis. This has this split in the retina, typically in the infranasal portion. The split occurs in the nerve fiber layer of the retina. The gene is present on the X chromosome, and patients frequently have this sort of stellate pattern in the fovea, which is related to the presence of cysts, like cystoid edema, or in all levels of the retina, but these aren't leaky cysts, unlike CME. Stargardt's disease, older term for this was fundus flavimaculatus, which means yellow spots. This is a interesting condition that I did some work on in the past. You can see these pisiform, that means like spots have been likened to fishtails. Some cases may have a vermilion appearance to the fundus, and they have Stargardt's atrophic macular degeneration, sort of similar to what we saw in atrophic age-related. We have loss of RPE cells leading to the loss of photoreceptors. Now, a very interesting feature found in many cases of Stargardt's disease is the so-called dark choroid, or sign of choroidal silence. There is a dark appearance on angiography that obscures the underlying choroidal pattern. And this is actually caused by the accumulation of abnormal lipofuscin pigment in the retinal pigment epithelial cells. This shows a PAS stain of peripheral RPE above and posterior RPE below. Again, the posterior cells are markedly swollen, don't have pigment. They're just chock full of PAS positive lipofuscin pigment. And there's significant amounts of lipofuscin out in the peripheral RPE above. Here's electron microscopy showing the abnormal lipofuscin pigment. Here's scanning electron microscopy of that case. You can see these fishtail-like aggregates of markedly enlarged RPE cells. These would be the cells without pigment, and then the more typical cells in between. Again, the more typical cells have apical pigment. Perhaps all the cells have lipofuscin. Perhaps this might be responsible for the appearance of yellow spots. It may be due to the detachment of the abnormal cells as well. Now, Stargardt's disease was always thought to be a classic RPE disease, but molecular genetics comes on, and it was discovered that the ABCR4 gene responsible for Stargardt's is only expressed in the rod outer segments. It's not expressed within the RPE. So the RPE changes are actually secondary to the problems with the photoreceptors. The gene mutation leads to the formation of a toxic derivative of vitamin A called A2E in the photoreceptor cells, in the outer segments of the photoreceptor cells. Again, every morning the tips of your rods break off and they're gobbled up and digested by the RPE cells through the phagolysosomal system. Well, this toxic A2E product poisons the phagolysosomal system and leads to this massive accumulation of autofluorescent lipofuscin. If enough of it occurs and develops in the cells, this leads to terminal constipation, dysfunction, and cell loss. This is a patient with Kern-Sayre syndrome, one of the chronic progressive external ophthalmoplegia syndromes. These patients do not have bone spicules. They have salt and pepper pigmentary retinopathy. Importantly, they have cardiac conduction defects like heart block. The patient illustrated here actually had been admitted to hospital several times in attacks of ventricular tachycardia. The histology shows so-called ragged red fibers in the extraocular muscles. If you do EM, you can see paracrystalline inclusions in the mitochondria. Now, this condition is caused by mutations in mitochondrial DNA. Many patients have a 5 kilobyte deletion. There are several other mitochondrial conditions that affect the retina. These include the MRF and MELAS. MRF is mitochondrial encephalopathy with ragged red fibers, and MELAS is mitochondrial encephalopathy with lactic acidosis and stroke. Here's a patient that has a golden appearance of the fundus. I saw a patient like this once when I was still doing refractions. I asked this patient if he had any problems, seeing at night. And he said, yeah, I do, but nobody ever asked me that. Well, this is he has Oguchi's disease, one of the heritable retinal disorders. If you take a patient with Oguchi's disease, a non-progressive form of night blindness, and you put them in a dark room for several hours, the fundus color will revert to normal, and that's called Mitsu's phenomenon. Again, this is caused by mutations in arrestin or rhodopsin kinase. Other heritable retinal disorders, Leber's congenital amaurosis, is sort of like a pediatric retinitis pigmentosa. I think with at least 11 different genes that are involved. The one you should remember is RPE65. This is the gene mutation that's currently targeted by FDA gene therapy. It can be remarkable recovery of vision in dogs and people with this form of Leber's congenital amaurosis. Best disease, vitelliform degeneration, the bestrophin gene is involved. And they also have lipofuscin accumulation forming the vitelliform degeneration. Sorsby macular degeneration gene is the tissue inhibitor of metalloproteinase 3. There's hyperornithinemia in gyrate atrophy. The ornithine acts as an RPE toxin. And rhabdoneural transferase and choroidal. Here's histology from a case with Sorsby's macular degeneration. We can see this massive deposit beneath the RP, like a giant basal laminar deposit.
Diabetic retinopathy is an important cause of legal blindness in working age adults. Background diabetic retinopathy is characterized by presence of deep and superficial retinal hemorrhages, hard exudates, cotton wool spots, and retinal edema. This is a trypsin retinal digestion showing normal retinal capillaries. This technique was developed by Kogan and Kuwabara many years ago. They demonstrated that the retinal capillaries are made up of two types of cells, endothelial cells and pericytes, which are present in a 1-to-1 ratio. They also noted that pericytes are lost preferentially in the early stages of diabetic retinopathy. You can see that these retinal capillaries still have endothelial cells, but we can see the basement membrane capsules where the pericyte cells once resided. In this photo, we can see pericyte loss in some of the vessels. Other vessels also have lost their endothelial cells, and these are what we see in capillary non-perfusion, essentially dead vessels, capillary non-perfusion. Here's a focus of capillary non-perfusion. This will lead to an area of retinal ischemia, causing an upregulation of vascular endothelial growth factor, which stimulates intraretinal neovascularization. Diabetic macroaneurysms are seen in this trypsin digest. In proliferative diabetic retinopathy, we have neovascularization that can occur in the optic disc or elsewhere in the retina. This can lead to what used to be termed retinitis proliferans, extensive areas of membrane formation, scarring, and tractional retinal detachment. This photo shows a frond of neovascularization rising from the retina. The inner retina has the appearance similar to that seen in inner ischemic retinal atrophy, but again, we're dealing with progressive loss of the capillary bed due to non-perfusion. In this case of proliferative diabetic retinopathy, we see neovascularization growing on the scaffold of posteriorly detached vitreous. There is blood between the detached vitreous, forming a subhyaloid hemorrhage, and also blood above the neovascularization as a vitreous hemorrhage. This is a post-mortem eye from a young type 1 diabetic. You can see blood vessels branching the space between the retina and the detached vitreous. And we can also see vitreous AP traction causing focal tractional retinal detachment. This is a scanning micrograph from that case. You can see neovascularization on the scaffold of detached vitreous. Another example here, we see vitreoretinal neovascularization, putting traction on the retina, causing vitreoretinal tractional retinal detachment in PDR. Another example of tractional detachment in PDR, here we see retinal traction and subretinal gelatinous fluid with foamy histiocytes. Another feature we occasionally see histopathologically in diabetes is lacy vacuolization of the iris pigment epithelium. The lacy vacuoles contain PAS-positive glycogen, which is dissolved out by diastase digestion. This is actually fairly uncommon. The sugar has to be very high at the time of nucleation to get this. Another feature that we see is diabetic thickening of the pigmented basement membrane, the basement membrane of the pigmented ciliary epithelium. When I have a case of neovascularization, I will immediately look at the ciliary body to see if the basement membrane is thickened. Of course, if the basement membrane is thickened here, it may be thickened in the kidney, and the patient is at risk for Kimmel-Still-Wilson disease. Patients with diabetes are also at increased risk for hemorrhage and increased risk for infection. One of the ones that we worry about is mucormycosis, essentially a bread mold infection that starts in the paranasal sinuses and then invades the orbit. This patient has a frozen orbit, a proptotic globe that's blind and cannot be moved. The hyphae of mucor tend to be very large. They're quite evident in routine H&E sections, and they have this propensity to invade and thrombose blood vessels, leading to ischemia. This is a patient with hemoglobin SC disease, the characteristic C fans of neovascularization that occur at the margin between the peripheral non-perfused part of the retina and the posterior perfused part of the retina. The term C-fan reflects the resemblance of these to the marine organism Gorgonia flabellum C-fan. This trypsin digest from a patient of hemoglobin SC disease shows the non-perfused vessels out in the periphery and a characteristic shunt vessel at the margin. Capillary non-perfusion. Here's a fluorescein angiogram showing the neovascularization entering the area of capillary non-perfusion. This young boy was referred by a school nurse for 20/70 vision. He had iris transillumination, and he has X-linked ocular albinism. This type of albinism just affects the ocular pigment. A case of this came to pathology down in Baltimore many years ago, and these patients tend to have very large macromelanosomes in the retinal pigment epithelium. The macromelanosomes also can be seen in skin biopsies. Peripheral microcystoid degeneration occurs out in the periphery of the retina in the vicinity of the vitreous base. The degeneration is characterized by the presence of Blessig-Iwanoff cysts. The cysts are filled with hyaluronic acid, shown here with an Alcine blue stain, and the hyaluronic acid is digested by hyaluronidase treatment. Reticular cystoid degeneration occurs posterior to typical cystoid degeneration. The split in reticular cystoid is present in the nerve fiber layer. Again, it's posterior to typical cystoid, and the split is in the nerve fiber layer. Paving stone degeneration or peripheral chorioretinal atrophy actually sort of resembles a cryo application. There's a firm chorioretinal adhesion, and this does not predispose to retinal detachment. Now, lattice retinal degeneration is a setup for retinal detachment because we see a vitreoretinal traction at the margin of an area of atrophic retina. The area of atrophic retina may have sclerotic vessels responsible for the name lattice. This case actually has some RPE proliferation as well. The area of the atrophic retina lacks an internal limiting membrane, so there's a pool of overlying liquefied vitreous. and higher magnification, atrophic retina with no IOM, sclerotic vessels, vitreoretinal traction. Again, this predisposes to tractional holes and retinal detachment. Summarize the abnormalities in this cartoon. Again, we have absence of the IOM, an overlying pool of liquefied vitreous, vitreous condensation and traction at the margins, with glial proliferation, focal retinal atrophy, vascular sclerosis, and intraretinal pigment migration. Pars plana cysts are fairly common in elderly patients. They're essentially a split between the pigmented and non-pigmented layers of the ciliary epithelium on the pars plana. The cysts are filled with hyaluronic acid, which is subject to hyaluronidase digestion. And there's a colloidal iron stain for acid mucopolysaccharide. As we discussed in a prior lecture, cysts do occur in the pars plana in patients with multiple myeloma. The cysts are typically white after fixation. The white cysts actually are a fixation artifact. The cysts are clear in vivo. Most eyes that are fixed by immersion in formaldehyde have artifactitious retinal detachments. You distinguish a true detachment from an artifactitious detachment by the atrophy of photoreceptors, the presence of subretinal fluid in the true detachment. In an artifactitious detachment, the photoreceptors persist, and there are frequently granules of melanopigment attached to the tips of the photoreceptors. Vitreoretinal traction, of course, is involved in the formation of horseshoe breaks or tears. The horse is always walking toward the optic nerve. Horseshoes, tears always have that orientation related to the mechanics of posterior vitreous detachment. Now, the vitreous can blind by vitreoretinal traction, causing retinal holes and tractional detachment. The vitreous can also cause visual loss when it serves as a repository for cells and material. In this cartoon, we see blood and blood breakdown products. We see iridescent particles, asteroid hyalosis and syncytial cinnalands. We see inflammatory cells. We see amyloid. We see tumor cells, retinoblastoma, and large cell lymphoma. Here's an example of a posterior vitreous detachment. Weiss ring is a condensation of the vitreous that previously encircled the optic nerve head, which is now detached. Again, vitreous opacities include blood and blood breakdown products, hyaloid remnants, inflammatory cells, asteroid hyalosis, syncytial cinnalands, cholesterol, amyloid caused by mutations in the gene for transthyretin, tumor cells, retinoblastoma seeds, metastatic skin melanoma has a propensity for vitreous metastasis, and primary vitreous lymphoma, the CNS and retina. Interestingly, Whipple's disease typically involves the gastrointestinal tract, can occur in the vitreous and can mimic lymphoma. This photo, Mike, shows chronic vitreous hemorrhage. We see ghost cells at the bottom, erythrocyte ghost cells or erythroclasts. We see macrophages of the ingested ghost cells and the golden brown hemosiderin pigment. There are two types of iridescent particles that occur in the vitreous. One type is fairly common, asteroid hyalosis. The other type, syncytial cinnalands, is exceedingly rare. Asteroid hyalosis is composed of spherules of calcium hydroxyapatite. These tend to be attached to the vitreous framework. They're sort of reminiscent of strings of popcorn on a Christmas tree. Here's a histopathology of asteroid bodies, which have been sectioned. They sort of have this grayish appearance. If you have intact asteroid bodies and put on Polaroid filters, you have this characteristic Maltese cross pattern of birefringence. The scanning micrograph shows that the asteroid bodies are attached to the vitreous framework. And recent studies have demonstrated that they are composed of calcium hydroxyapatite. It used to be said that they were made up of calcium soaps, but there's really no evidence for that recently. This is a fundus photo from a patient with the Indiana or serine 84 type of familial amyloidosis. This is the postmortem eye. Again, the patient had had a prior vitrectomy, but there's certainly a lot of amyloid left. Histopathology shows the detached apple green amyloid material. Again, this is the type of amyloid is comprised of atypical transthyretin. It's a transport protein for vitamin A and thyroid hormone. Again, the transthyretin mutations are responsible for a number of different types of familial amyloidotic polyneuropathies. And here's the H&E section, and again the apple green birefringence of the Congo red stained specimen. Primary vitreoretinal lymphoma typically is a disease of elderly patients who may have dementia and present with bilateral vitritis. The prognosis is poor with a medium survival in different series of 12 to 35 months. There is no involvement outside of the CNS, and patients typically die from CNS disease. Diagnostic vitrectomy typically shows a cellular infiltrate that is extensively necrotic and contains large atypical lymphocytes. The atypical lymphocytes are large, they have nuclear protrusions and prominent nucleoli. There are usually numerous necrotic cells. In most cases, the atypical lymphocytes stain positively with the immunohistochemical stain CD20. This confirms that the lymphocytes are B cells. Primary vitreoretinal lymphoma is a form of CNS lymphoma. It involves the CNS, the vitreous, the retina, and the space between the retinal pigment epithelium and Bruch's membrane. Some patients have large yellow sub-RPE deposits. Primary vitreous lymphoma usually does not involve the uveal tract. The uveal tract and not the vitreous typically is involved when systemic large cell lymphoma involves the eye secondarily. Most cases are large B-cell lymphomas. These are classified as non-germinal cell B-cell-like or activated B-cell diffuse large cell lymphomas. Rare cases of vitreous involvement by T-cell lymphoma occur. I have seen several cases of vitreous involvement in patients with mycosis fungoides. Flow cytometry of vitreous fluid may be unsatisfactory due to extensive necrosis. An interleukin 10 versus interleukin 6 ratio greater than 1 helps to confirm the diagnosis. PCR can also be used to detect the L265P mutation in the MYD88 gene. This mutation is present in 80% of cases.